Vamos a hacer el bloque de la media mañana. Mientras se organizan, quiero recordarles a los que van a presentar el examen mañana, un pequeño aviso parroquial, como decimos en mi país. El examen se hará a las 8 de la mañana en el Salón Coral Island, en el piso del primer nivel, porque algunos están interesados, muchos llenaron la solicitud del examen previamente por internet, pero si alguno no la llenó y quiere hacer su examen, es la última vez que lo vamos a hacer sin costo, es muy interesante, y a las 8 de la mañana, sábado 10, Coral Island, planta baja, los esperamos. El examen es el examen de excelencia académica de Iberoamérica, es el equivalente al Diploma Europeo de Radiología en su proporción, y es un proceso de mejoramiento de la calidad que está haciendo el Colegio Interamericano a través del sistema de certificación y acreditación. Muy bien. Vamos entonces a comenzar el bloque. Tenemos dos profesores nuevamente y tenemos un profesor que todavía no ha participado, es el profesor Aydingos, es profesor médico radiólogo en músculo esquelético de Turquía, Ankara. Él nos puede contar dónde es su hospital y darnos un breve recuento de su escenario. Él también trabaja en San Luis, en Estados Unidos, o ha trabajado como profesor en San Luis, Estados Unidos. Entonces, él nos va a hablar de resonancia de tobillo y pie en niños, y posteriormente la doctora Jenny Bencardino. El doctor Audingos es parte del proceso y del apoyo de la Sociedad Europea de Radiología dentro de la alianza de trabajo en este bloque de músculo esquelético. Welcome, Dr. Audingos.
Thank you, Dr. Restrepo, for this kind introduction. And good morning to you all again. So in this first of my two lectures, I will be talking about MR imaging of the foot and ankle in children. I think you need to go to the other one. This is Dr. Bencardino's presentation. So I'm really delighted to be here, to be with you. This is my third visit to Cancun, fifth to Mexico, and sixth to Latin America, which is one of my favorite places in the world, Latin America in general. And I really enjoy being here. Although I do not speak Spanish, my hope is that with my English, I will not be really, giving you a lot of trouble, but rather be as straightforward as possible.
I see presentation in the computer. Do you have that in
Yes.
pen drive?
Oh, yes, I do, but perhaps we can change with Dr. Bencardino, and then I will resolve the problem, because I know that I uploaded it.
The first one is the ankle or the other one? Because there was one there.
I know that we have uploaded there, but I can check, perhaps. I will take a look. Perhaps Dr. Bencardino may take my place, and then we will save time.
Okay.
Is it okay?
Yes. Hay un pequeño tema técnico con la charla del doctor, entonces vamos a revisar. ¿Pueden chequear que la charla del doctor estaba en el computador?
Yo lo vi a él cargar.
¿Está cargada? ¿Puede chequear, por favor? Hay muy buen tiempo. There is a lot of time, doctor. So we can wait a little bit.
Sí, está bien.
Is this okay? Perfect, no problem. Actually, 1 hour is very nice time. There is a trouble with.
So this is somewhat blown up, the slide size. Could you please check the slide size, because this is somewhat, overblown? This is the normal presentation, but then this is a little bit enlarged. It should be a little bit smaller, because I had the...
El profesor está preguntando si pueden minimizar un poquito la imagen en la pantalla, que está muy...
So in the projector, it is a little bit overblown. It should be a little bit more focused. Yeah, I think that's fine. This one is okay. Yep.
Thank you.
Thank you. So once again, my first lecture today will be on MR imaging of the ankle and foot in children. And the learning objectives as listed here are about some technical and anatomic issues regarding MRI of the ankle and foot in children. And we will be talking about some normal and variant findings. And finally, actually interspersed within the lecture itself will be MR imaging of the lesions in the ankle and foot in children. In terms of general considerations, we need to consider that the skeleton is growing in children, which means that ossification centers are not necessarily fused. Actually, they are not fused throughout the childhood, and the fusion itself will come by phases, as you know, and will not be completed until the age of around 22, 23, sometimes even 24. There could be some residual hematopoietic bone marrow, which could be still seen. And then it is also important to realize that there are some lesions more common in the pediatric age group, but then there are some lesions also which may be encountered in adults that are also seen in children. As you know, the mainstay of imaging in the ankle and foot would be radiography, and this would show osseous lesions. They would also allow measurements of some conditions. Ultrasound is quite useful as a cross-sectional imaging modality, and especially its dynamic capability is unique. So MR imaging is by no means the only way to image bones or soft tissues in the ankle and foot, but as we will see, there are some advantages to MRI that comes with some of its unique aspects, like comprehensive depiction of bones and joints and soft tissues, superior contrast, and lack of ionizing radiation, which is all the more important in the pediatric population. Usually, since the extremities are small in children, it is possible to image entire foot in a single field of view, but still smaller fields of view should be attempted in order to increase SNR, signal-to-noise ratio. So these are some of the considerations that we need to take into account in the imaging of pediatric ankle and foot. In older children, a dedicated foot and ankle, sometimes knee, or sometimes even head coil would do. In smaller children or babies, smaller surface coils would be utilized. Immobilization is so important in terms of obtaining clear images, as you know, and this may necessitate the use of liberal padding, not necessarily related only to the ankle and foot, but rather to other areas where the children would be more comfortable, like the knee and sometimes the hip. And sometimes anesthesia would be required, as you know. These are challenges that we face with imaging in children in general. In terms of anatomic considerations, we need to remember that there are three parts of the foot: the hind foot, the midfoot, and forefoot. Hind foot is composed of the talus and calcaneus in terms of tarsal bones. The remainder of the tarsal bones make up the midfoot, and the more anterior portion of the foot is called forefoot. Generally, it is important also to realize that MR imaging of the foot is not necessarily inclusive of the ankle. MR imaging of the ankle is a separate study in terms of making high quality, high resolution images of the foot, especially in older children. We need to make sure that ankle is a separate study and the foot itself is another one. In terms of MRI of the ankle, these are our imaging planes. Just a brief overview of them. The axial images should begin through the distal tibia and go all the way to the heel subcutaneous tissue. And the axis of the axial images would be parallel to the axis of the calcaneus. The sagittals would be parallel to the long axis of the talus, as shown here, and should cover the medial most aspect of the medial malleolus and the lateral most aspect of the lateral malleolus. The coronals should cover the very posterior aspect of the Achilles tendon, and then they should go through the metatarsal bases anteriorly. And they should also be perpendicular to the sagittals in terms of the axial alignment of the coronal plane. These are the recommended MRI sequences of the ankle. Although there may be variations from institution to institution, usually sagittal stir or T2 fat set along with T1 weighted are utilized, and then the fields of view are usually in the order of between 14 and 18 centimeters with a slice thickness of around 3 to 4 millimeters. Normally, in the routine setting, we are not supposed to give IV contrast in the MR imaging of the ankle. However, when there is a concern for masses or osteomyelitis, IV contrast could be utilized. MR arthrography is utilized in the study of in the study of loose bodies and also the stability of talar dome osteochondral lesions. I'm going to show you an example. We usually utilize fluoroscopy guidance in my institution in Ankara, but ultrasound could also be utilized in terms of MR arthrography of the ankle. Anteromedial and sometimes anterolateral approach may be used in this regard. And as you know, we utilize T1 weighted fat suppressed images along with some T2 weighted fat suppressed images also during MR arthrography of the ankle. 3D imaging may also be used for this purpose along with these sequences. When it comes to the foot, our imaging planes are once again sagittal, coronal, and axial, and their coverage is listed here. They should go all the way from the navicular posteriorly to the tips of the toes, and they should be perpendicular to the long axes of the second and third metatarsals in terms of coronal images. And their alignment in the axial plane should be parallel to the first to the fifth metatarsals to make best use of the anatomy we have there. The sagittals should be perpendicular to the axials, as shown here. And these are the recommended MRI sequences. IV contrast usage may be more common in the foot when compared to the ankle. And the fields of view are generally between 10 to 14 centimeters with a similar slice thickness of 3 to 4 millimeters when compared to the ankle. So once again, stir sagittals and T1 sagittals are almost always obtained. And then we have a selection of T2 weighted fat saturated images on the coronal and axial planes. Depending on pathology, we may change the sequences that we use. Whenever things like Martin neuroma or osteomyelitis is a concern, IV contrast is usually given, or when there is a concern for soft tissue mass in a child, IV contrast would be utilized. Otherwise, no IV contrast is used. There are some technical pitfalls, and the major ones are listed here. We will go through them one by one. With T2-weighted fat-saturated images, as you know, we have the problem of fat saturation, or a uniform fat saturation, I should say. With STIR, this is usually overcome, this particular effect. And this is the same patient. As you can see, STIR has a better fat saturation. So I would recommend using a sagittal STIR rather than T2-weighted sequence. But if your fat suppression is adequate, then you could also go with a T2 fat set for this purpose. Magic angle phenomenon is another condition that we need to that we need to be aware of, and this is unique to the musculoskeletal system. And in order to meet the criteria of magic angle phenomenon, these are the conditions that we need to remember. There should be collagen-containing structures. They should be aligned 55 degrees with respect to the main magnetic field. And MR sequences with a TE of less than 37 milliseconds would show artifactually increased signal within the tendons. So this one has an angle of about 55 degrees here at the lateral aspect of the foot, those peroneal tendons. And when you have this 55 degrees of alignment, in whatever plane you obtain your images, like those axials, you will have this artifactually increased signal here, which is not visible here because the TE is higher here when compared with the other one. So as you can see here, if you compare the TE of these two sequences, this one is definitely less than 37 and this is higher. So we do not run into the problem of magic angle phenomenon here on this particular sequence here. So one thing to do is to look at sequences with a TE of higher than 40 or 37 milliseconds. Another thing that was proposed by a group was to obtain the images in a prone position as shown here, so that ankle tendons would not run into the problem of, would not give the problem of magic angle phenomenon. But honestly, we do not use this in our institution. Rather, we make use of the sequences with a TE of higher than 40. Even if they are like PD fat set, we make sure that they are between 40 and 50 milliseconds rather than anything beyond, below 40 milliseconds. So another problem may well be the fold-over artifact, but then there are these issues may be overcome with some real simple methods like fold-over suppression, which is so unique, which is so common in the systems. Of all the structures listed here, I will not be talking about the tendons, definitely. This is the topic of Dr. Bencardino, but perhaps we may briefly remember the ligaments in the ankle. The lateral ankle ligaments, as you know, are more prone to injury. And then we have the anterior and posterior tibiofibular ligaments, as well as the lateral collateral ligament complex, which is anterior talofibular ligament, posterior talofibular ligament, and the calcaneofibular ligament. So those three are the ones that make up the lateral ankle, lateral collateral ligament complex. And the injury to these, especially to the anterior talofibular ligament, in the setting of sports activities, are being increasingly seen in adolescents who are more active than in the past in terms of sports. So it is important to realize that those ligaments may well be torn even in adolescents, especially those two, anterior talofibular and calcaneofibular ligaments. Common things being common, the anterior talofibular ligament would be the most commonly injured one, as you remember. So it is this particular structure here, which is shown in green on the right. And this is the posterior talofibular ligament. And this is the calcaneofibular ligament, which sometimes may be well seen on coronal images, but since its alignment is somewhat oblique, we do not expect to see the entirety of the ligament on a single image. Rather, it will be seen on consecutive images, be it on the coronal plane or axial plane. So the distal tibiofibular syndesmosis is made up by the anterior and posterior tibiofibular ligaments, as shown here, the anterior one, and the posterior one, shown in green on the right. And we also have the interosseous ligament, as shown here, which is part of the distal tibiofibular syndesmosis. So all in all, this was the lateral aspect of the ankle. In terms of the medial and plantar side of the ankle, we have the spring ligament complex, which is also known as the calcaneonavicular ligament. On the coronal images, it is seen as shown here. And on the sagittals, sometimes you would see the spring ligament recess right here, which should not be mistaken for a ganglion cyst. It's a normal recess right here, which is seen like this on the coronal and sometimes on the axial, like this, just between the components of the spring ligament itself. So once again, this is not a ganglion cyst, but rather a normal recess of the spring ligament. The deltoid ligament is actually the posterior tibiotalar component, or the deep component of the medial collateral ligament complex, which comprises of some different components as shown here, like 5 of them. And this is how the deltoid ligament would look like on the axial images. There is some striation which is normal, which should not be mistaken for any injury. So as you know, some ligaments would be seen with some striations, which is a normal finding, and the deltoid ligament is one of them. We have the calcaneal ligaments between the talus and the calcaneus, and overall we have a lot of ligaments there in the ankle and foot, but those are the ones in terms of the ankle that should be routinely inspected, and that should be commented on when there is some sign of injury. So now I will be talking about some normal conditions specific to the pediatric age group, as well as some anatomic variants that may be associated with symptoms. And this brings me to my first question here, which is a 12-year-old male with ankle pain. And I just want to ask, what do the arrows point to here? Is this an old physial fracture? Is this a physial bar? Is there an osteochondral lesion? Or is this what is called Kamp's bump? If you have your application, perhaps you may vote now. Can we see the results here? Okay, so apparently we have a split between the physial bar and Kamp's bump, and we will now see what we have here. Can we go back to the presentation? So this one here is known as Kamp's bump, which is a normal appearance of the physial line at the distal tibia. It is the superior convexity of the growth plate in the anteromedial quadrant of the distal tibial physis, as shown here. And it is the first sign of physial fusion. Closure usually occurs about 12 to 13 years of age and should not be mistaken for a fracture or abnormal physial fusion. And we will see what a physial bar looks like, as shown here. This is a 6-year-old female from Radiopedia. I will show you one of our patients also, but then this also nicely depicts a patient who had some physial bar at this particular location, which is thought to be the result of injury or infection to an unfused physis, which would result in the closure of the physis prematurely. And this connection may be osseous, or sometimes it may be fibrous. And if there is the involvement of the physis less than like 50% of it, then the resection would be a consideration, a surgical resection. So here are the conditions that are associated with the partial premature physial arrest. And this is a patient that I have seen in my institution. She is 11 years old and then jumped from a height 1 year previously and sustained some fractures. And you can see that there is this premature fusion at this particular location. And there is this evidence of a remote fracture there. So this area should be carefully inspected, especially around the age of 12 to 13. We may sometimes see those growth arrest lines as shown here. And these are also known as Harris lines. They are alternating transverse rings of sclerosis at the metaphysis of a long bone. And we may also see them in patients with some history of surgery, as in this 8-year-old female with Ewing sarcoma on the right. You can see that there had been some arrest of growth on the left side here, as shown by these lines here. So these lines may also be seen. These are some abnormalities that we could see in the setting of some previous history of surgery or immobilization, but sometimes they may also be seen even in normal settings. So it is not always easy to discern whether they are secondary to some real issue or they may just be developmental. But whenever there is some surgery like this, there is increased possibility of seeing them, and you can see that they are there. In terms of such lines, you can see that they may be sometimes vertical, as shown here, not only necessarily transverse, as oriented here. So there may be some interesting patterns of those growth arrest lines. And sometimes you can have this bizarre appearance of like osteonecrosis, but then this is not osteonecrosis. This is the intraepiphyseal silhouette, which also tells me that there had been some growth arrest at one point. And you can see that this patient actually 3 years earlier did not have this condition, but rather due to the right tibial Ewing sarcoma, she sustained some immobilization, and this also resulted in growth arrest as shown here. They may be very interesting at times, as shown here in the talus of this 48-year-old from my institution who fell at 7 years of age and had some growth arrest. So physial bars, growth arrest lines, and intraepiphyseal silhouettes are things that we need to consider when we see some funny-looking thing at the distal ends of the bones. They may well represent some growth arrest at one point in this person's past. In terms of immobilization, it is not only growth arrest that we encounter, but sometimes we also see these subcortical hyperintensities on the fluid-sensitive sequences as shown here, all the way, surrounding the, just underneath the cortices of the bones. This is a 31-year-old male, but then apparently there had been some splinting for about 3 months earlier. So there had been some immobilization. And this child, 14-year-old male, had a first metatarsal stress fracture 3 months previously, and then you can appreciate that there is these cortical and subcortical increased intensities at the fluid-sensitive sequences, which are suggestive of immobilization. So this was how the stress fracture looked at the outset, right here, and there was not any such cortical or subcortical increased intensities on the in the fluid-sensitive sequences, which developed over time due to immobilization. Metatarsal stress fractures are definitely an issue, and then most of the time they may be, or many of the times they may be picked up on plain films if looked carefully, but then sometimes there is the need for MRI. And in this particular patient here, a 15-year-old girl, there is this navicular stress fracture, which has this characteristic appearance of a sagittal alignment of the fracture, just at the middle of the navicular bone, as shown here, surrounded by edema-like signal that surrounds the fracture itself. It is not a complete fracture, but it is there. So whenever you see this pattern, you should realize that you are looking at a navicular stress fracture, which is characteristically aligned like this here. Köhler's disease, as you know, is a childhood onset avascular necrosis of the navicular bone. And this is an often self-limiting condition. And it is not surprising to have these patients having their navicular bones revert to normal over time, over a few years. So these do not necessarily stay like this or fragmented like this as shown here. And as you can see, whatever fragmentation there is, it is usually along the same line which the stress fracture would take place. So there is this increased stress at the middle section of the navicular, which tells us that the stress fractures are also more commonly expected there. So this is how this looks like on MRI. And you can see that there is also most likely some reossification going on there, which would most likely result in a normal appearance over time. And this is how CT of this patient looked like. Once again, the fragmentation looks like a stress fracture bilaterally, but then we know that this is avascular necrosis of the navicular bone. Here's another patient, this time a subchondral or subcortical fracture of the second metatarsal, which is known as Freiberg's disease. And as you know, this is more common in adolescent girls, this fracture here. This may have to do with an elongated second metatarsal and with the use of high heel shoes. And especially in adolescents, this may well be an issue with adolescent girls, which may result in this kind of actually a stress fracture just underneath the subcortical portion of the distal end of the distal portion of the second metatarsal. And there is a lot of edema-like signal, as you can see on these fluid-sensitive images. So this brings me to my second question, and it is, how would you characterize the hyperintense foci in the bone marrow in this particular patient, who is a 13-year-old boy with ankle pain? Is this normal? Is this neoplastic infiltration? Is that stress reaction or osteonecrosis? If you answer the question, we can perhaps go to the results in a bit. So can we see the results now? Okay, so once again, we have a split between a normal, between normal and stress reaction. We can go back to the slide here. Well, the answer to this one would be normal because in adolescents, such high intensity lesion, appearance is actually normal. If you remember the age-related changes in the content of bone marrow, we know that there is this age-related change over time with some residual marrow at the ends of the bones during adolescence, which is also true in the ankle. So it is not surprising to see such hyperintense foci which are neatly and quite uniformly located in the bones of the ankle. This is another one, like a 9-year-old female. And these are actually normal, and they usually disappear after the age of 15. I actually liken them to this painting by Vincent van Gogh, the Starry Night painting. And this collage was given to me by a radiologist friend of mine who inserted this picture from NASA's Jupiter-Juno spacecraft, which is actually orbiting Jupiter these days. And this was taken of Jupiter's North Pole, I suppose, several weeks ago. And this quite looks like this appearance here, which is a normal appearance. But we will see that this may not always be the case in children. One of the hallmarks of the of such foci would be they are almost uniformly sized with quite homogeneously with a quite homogeneous distribution. If you compare this with this patient, who is a 16-year-old male with ankle pain following strenuous exercise, now how would you characterize the hyperintense foci in the bone marrow? This is my question this time. Once again, with the normal foci of residual marrow, usually they are quite similar in size, and then they are quite homogeneous in distribution. So is this normal? Is this neoplastic infiltration, stress-related bone marrow edema, or osteonecrosis? So the answers we can take now, I suppose. Very good. So this time we have stress-related bone marrow edema, and as we will see, they are not as uniformly distributed as the normal residual marrow in children, in adolescents, and they are of quite different sizes. And this gives them the characteristics of a stress-related bone marrow edema appearance. Now we are going back to the presentation, I suppose. So this particular condition is related to intense physical activity or altered biomechanics. For instance, due to a tendon tear, there is the use of some splint or something that changes the biomechanics of the extremity for a while. They could be symptomatic or asymptomatic. They are usually transient in nature. And one of the differential diagnostic considerations, although there are many, would be reflex sympathetic dystrophy, where there would also be associated soft tissue edema usually. So this is one of the things that should be considered. And since radiologists usually don't see the patients these days, it is important to look at the subcutaneous tissue to look for signs of edema. And then if there is edema, this could well be like reflex sympathetic dystrophy. This condition here is a variant of this particular condition. As you can see in this patient, there was also, along with stress-related bone marrow edema, the incomplete fusion of the ostrigonum here, right here. And then if you look at the posterior aspect of the ankle, just posterior to the ostrigonum, you can see that there is this soft tissue edema, which tells me that there is also posterior impingement along with the stress-related bone marrow edema, which is distributed through the bones of the ankle. Posterior ankle impingement is also known as ostrigonum syndrome. And then you can see that in this patient, there is this edema surrounding the soft tissue edema surrounding the ostrigonum. And especially in children between the ages of 8 to 11, ostrigonum, actually the stiada process is supposed to close in terms of physial fusion. But sometimes this secondary center of ossification would not fuse, and then this would remain for a while. So whenever we see such an appearance in a child between the ages of 8 to 11, there is the possibility of looking into a normal condition, but some edema-like signal surrounding the presumed location of the physial union here tells me that there could be some instability resulting in such edema-like change there. So if the patient is symptomatic posteriorly, this may well be the reason of the symptoms there. So one of the clues would be to look at edema-like signal surrounding the physial fusion process there. So here's a patient, 16-year-old male this time. Certainly there had not been the closure of the ostrigonum here. And then you can see that there is extensive edema surrounded by posterior soft tissue edema, which tells me that there is this posterior ankle impingement along with the incomplete fusion of the posterolateral talar process. Another issue that we need to consider would be tarsal coalitions in the ankle and foot in children, especially the ankle of the children, of course. And then you can see that in this talocalcaneal fusion, which could be synchondrotic, synfibrotic, or synostotic, on this one, most likely one of the two, those two, there is some edema-like signal, which tells me that there is some instability causing in some mechanical problems there, giving rise to the presence of such edema. And this may well be related to the patient's symptoms there. Osteonecrosis is obviously one of the conditions that we need to consider in terms of the bones in the ankle and foot. And in a patient with acute lymphoblastic leukemia, it is not uncommon to have such lesions, which are usually the result of treatment. So this brings me to my fourth question, which is about a 13-year-old boy with ankle pain. So what is your diagnosis here? Are we looking at an osteoid osteoma of the calcaneus? Do we have a vascular malformation of the medial soft tissues? Do we have a prominent peroneal tubercle? Or do we have adventitial bursitis? Perhaps we can look at the answers now. Okay, very good. I mean, those two actually, okay, there had been some change. Still, the higher percentages look like the correct ones because we have this prominent peroneal tubercle associated with adventitial bursitis in this case. Let me show you what we have. If we go back to the presentation, so we have those two conditions here. We have a prominent peroneal tubercle. Unfortunately, we don't have a definite threshold for this, but whenever we see some abnormality of the surrounding tendons or the overlying soft tissues, if there is what appears to be a prominence of the lateral peroneal tubercle, as in this patient, this particular area here shows that this peroneal tubercle is prominent, and there is this, if you compare this with somebody without a prominence of the lateral tubercle, we have to make sure that we are looking at the overlying soft tissues, and then there is this adventitial bursa here, the adventitial bursitis. Another condition would be the tendinosis of the peroneal tendons. This patient also had this also. These are actually images with a TE of higher than 40, so we are not looking at magic angle phenomenon. So there is some tendinosis of the peroneus longus here, as you can see. And with the other options that we have, perhaps you might have become tempted to go with an osteoid osteoma of the calcaneus, but you know that this area here of the calcaneus at the Guisan angle has these fibrocystic change-like appearance, which actually are spaces surrounding some vascular structures there. There are some remnants and also some active vessels there, which can be surrounded by such high signal. And such vascular remnants should not actually mislead you into thinking about some other possibility there. If it were an osteoid osteoma, and if it were an active one causing ankle pain, then we should be most likely expecting to see some edema there of the bone marrow and also the surrounding structures, I mean soft tissue structures. So here is another patient with prominent vascular remnants at this particular area. A 10-year-old female. So this should be considered normal. This brings me to my fifth question, which is the case of a 12-year-old boy with lateral ankle pain. And what is your diagnosis? Do we have pes planus, accessory anterolateral talar facet variant, or talocalcaneal impingement. Once again, a 12-year-old male with lateral ankle pain. The options are pes planus, accessory anterolateral talar facet variant, and talocalcaneal impingement. If you look at the results, well, looks like we have, okay, the majority goes with talocalcaneal impingement, and also pes planus is also marked here, and then this facet variant here. Okay, let's see what we have here. If we can go back to the presentation, so the answer here would be all three actually, because we have pes planus, which is actually diagnosed with a standing radiograph, not with MRI, because that could be really misleading. So we have this calcaneal pitch angle of less than 15 degrees and even less than 10 degrees here, which tells me that we are looking at a pes planus here. We also have this particular variant, which I'm going to talk shortly about, and then we have the talocalcaneal impingement, which is characterized by this edema-like signal at this Gissan angle here. And this variant that I'm talking about is this particular structure right here. Normally, there is no such facet here, but then it was described somewhat recently that there is this variant, and this may be associated with talocalcaneal impingement, especially in the background of pes planus. This was a patient whom we did MR arthrography on for the concern of some talar osteochondral lesion. There was no such lesion, that's for sure, but then we had this condition here of this accessory anterolateral talar facet variant. And as you can see, there is surrounding bone marrow edema-like change here. The pitch angle is less than 15, as shown here. This study we did a few years ago, and that was published last year. This particular facet may be present in symptomatic as well as asymptomatic ankles, or I should say asymptomatic as well as symptomatic ankles. So some of us in this room may well have this variant, but if you also have pes planus and this variant, then there is increased possibility of talocalcaneal impingement. So this is what a normal articulation would look like between the talus and the calcaneus, and there is this condition with this facet here. So there is this patient with this facet. Actually, not necessarily a patient, once again. An asymptomatic person may well have this facet, which actually has some overlying cartilage, hyaline cartilage. So this is why this patient had these three conditions. Here is another patient, once again a 16-year-old male with this condition, and you can see extensive talar and calcaneal edema-like signal at the bone marrow surrounding this particular area where there is a prominent anterolateral talar facet. And this is how it looks like on coronals, and this is how it looks like on the axials. So these patients usually have hindfoot valgus deformity also, and it is important to realize that this facet may need to be excised in order to relieve the patient's symptoms. So it is important to talk about the possibility of such a facet there. Here is a 12-year-old female who twisted her ankle during basketball training, and which ligament do you think is torn? This is my sixth question. The anterior tibiofibular, talofibular, or posterior talofibular ligament, or just given this particular image here, is it the calcaneofibular ligament? Perhaps we can wait for another 10 seconds or so. We can look at the results now, I suppose. The majority has it correct. We have the anterior talofibular ligament condition here. Anterior tibiofibular ligament actually is not seen in this particular image. It should be a little bit above this particular level because we have the distalmost aspect, or rather we are closer to the tip of the fibula on that particular image there, if we can go back there. Going back to the presentation, this particular concavity here tells me that we are close to the tip of the fibula rather than at the level of the anterior or posterior tibiofibular ligaments, which are not seen here. So on this particular patient, we had the tear of the anterior talofibular ligament. One important thing to consider is if there is an osseous avulsion associated with such tear, we can overlook them on MRI. So there may be the need to have some additional studies, and actually plain films may well show them, as shown on this Mortiz view here, but then to really appreciate the location of the avulsed bone, it is important to have CT sometimes, and this is what surgeons want. And you can see that this area here was the actual location of this avulsed fragment in this patient with anterior talofibular ligament tear, who is a different patient. So this brings me to this other question. But then, as you can see, we have the acute injury of the anterior talofibular ligament here. But if you look at the other structures, I have already talked about the spring ligament, and this is the tibiospring ligament here. You can see that in this gymnast who had the repetitive injury of her ankle for quite a while, there is some increased signal within the tibiospring ligament here, which tells me that there is some there had been some chronic trauma there. It is also somewhat thickened. And this is the anterior talofibular ligament, which is partially torn here, as you can see, with surrounding edema. And if you look more inferiorly, you can see that the calcaneofibular ligament also has some increased signal here, and then some tear there at the anterior-most aspect here. So in this particular patient, we not only have the anterior talofibular ligament partial tear, but also we have the calcaneofibular ligament tear and also the chronic injury to the tibiospring ligament, which is not so surprising in this gymnast. These are the coronal images, and this is how the calcaneofibular ligament goes. You can see that these are more anterior images, and those are the posterior images. More anteriorly, there is this tear within the calcaneofibular ligament here. So this brings me to my 7th question, which is a 12-year-old boy with heel pain. What is your diagnosis? Is this normal bone marrow, stress fracture, or osteonecrosis, or severe disease? So we have a plain film, a CT, reformatted image, sagittal, and then we have the T1 weighted and T2 weighted fat suppressed sagittal MR images. If we can look at the results, I don't know if this is the end of it, but apparently we have the correct answer here. We still have the correct answer, which is severe disease. If we can go back to the presentation now. Severe disease is actually, perhaps severe injury would be a better term, because this is likely a stress reaction of the growing skeleton during increased strenuous activity of adolescence. This is a self-limiting condition, and the hallmark here would be the bone marrow edema-like signal surrounding the calcaneal apophysis here on both sides. Sometimes this may be limited to one of the sites, but then such signal is necessary to make the correct diagnosis of severe disease. Otherwise, what appears to be some sclerosis, as in this patient here, does not necessarily justify the presence of severe disease. This condition has nothing to do with severe disease because, once again, the signal here on both sides is normal. Just some increased sclerosis here does not mean that the patient has calcaneal apophysitis. So this should not mislead you to think that such increased density on plain films would imply severe disease. This is why MR imaging is sometimes needed in these patients. Plantar fasciitis in this region is also another consideration. In terms of some lesions here in the calcaneus, we can see the simple cysts, as in adults, or aneurysmal bone cysts, like in this patient here, with these fluid or fluid blood levels, a multi-cameral lesion. And this patient had an unossifying fibroma. Actually, this was seen during filming for ankle sprain. After it subsided, this patient also had this MR imaging study, which I think was somewhat redundant because this particular appearance here would also only tell me that this is a don't touch lesion. This is a benign fibroosseous lesion, most likely an unossifying fibroma. Osteomyelitis may well be seen in children, and with such sinus draining an osteomyelitic foci, an abscess-like foci in the calcaneus here to the lateral aspect of the skin. Foreign body granulomas may well be seen. The reason we do MRI on these would be to either locate the foreign body itself. As long as it's not metallic, we can do MRI, and then plain film did not show anything there. So this patient stepped on a nail which was removed 1 year earlier. Apparently there was some paint overlying the nail itself, because this is what came out after surgery here. Some small speck of paint which had this reaction surrounding it. We can definitely have enthesitis-related arthritis, which would give us this quite non-specific appearance of synovitis and also tenosynovitis along the ankle. This patient also had the sacroiliitis bilaterally, as you can see. And I think this brings me to my final question here, which is the case of a 13-year-old female with ankle pain. And what is your diagnosis? Is this an osteochondral lesion, a stress fracture, a Brody's abscess, or osteodosteoma? I think we can take a look at the results now. Okay, the majority has it correct. We have an osteodosteoma here. Of course, I did not give you the detailed history here, which would also help normally. Pain that increases during night and responds to aspirin. If we can go back to the presentation itself. This patient actually had this focus of osteodosteoma right here, and then this was treated with radiofrequency ablation as shown here. These lesions actually usually have a surrounding bone marrow edema-like signal here, and also some soft tissue edema, which is quite characteristic. Brody's abscess would definitely be a consideration, but with Brody's abscess, we would expect to see, perhaps not always, but sometimes you would expect to see what is known as the penumbra sign, the presence of some high intensity rim surrounding the lesion just underneath the sclerosis here on pre-contrast T1 weighted images. This sign has a high specificity for musculoskeletal infection, not only for bones also, but also for soft tissues. And with osteodosteomas, I would like to bring to your attention the description of this vascular groove sign, which actually tells me that there is this increased presence of feeding arterioles surrounding an osteodosteoma. Here is one of our cases in the tibia, and this is a sclerotic bone island right here. So this is the osteodosteoma here, and then these are the prominent vessels, which gives us the vascular groove sign. And in this 9-year-old female, in the foot, we had this focus of osteoid osteoma, this one here, and then this prominent vessel here, as you can see right here. So prominent vessels surrounding such foci would also help you to make the diagnosis of osteoid osteoma. So I think I will stop here. I had some more questions, but I think my time is up. And I will now leave the podium for Dr. Restrepo. And thank you for your attention.
Thank you very much, Dr. Eidingos.